Hello everyone, my name is Charvi Thanakanti and I'll be presenting on a global health issue that's both preventable and persistent, the HPV vaccine divide in rural communities. A little bit about me, I'm a rising senior at Denmark High School in Atlanta, Georgia, where I am the vice president of our Science National Honor Society. I've also been doing classical Indian dance since I was 6 years old. I am a research intern at Morehouse School of Medicine exploring HPV vaccination in rural communities, and I'm also an aspiring medical professional. So what is HPV really? HPV, standing for human papillomavirus, is the most common sexually transmitted infection globally. The peak infection ages are 15 to 25 years old, and there's over 200 different strains. The high-risk types, specifically type 16 and 18, can cause virtually all cervical cancers and also represent significant portions of other cancers, such as throat and genital cancers. There are 30 million new infections globally with HPV, which means that 80% of the global population will get an HPV infection at least once in their lifetime, stressing just how common HPV is. The good news is that 90% of HPV infections naturally clear within 2 years thanks to our immune systems. But what happens when it doesn't clear? This is how HPV and cancer are linked. So here is what happens. When HPV infects cells in the cervix, throat, or genital areas, most infections that clear quickly, also known as transient infections, shown in the graphic, are not at risk. But when you have a persistent long-term infection, that is when you can have cancer. So when high-risk HPV persists, the virus starts producing proteins that interfere with the cell's normal growth controls. And without these controls, cells begin to grow abnormally, developing precancerous changes, which eventually progress into full cancer. Every year, 660,000 women are diagnosed with cervical cancer worldwide, and what's heartbreaking is that 99% of these cervical cancer cases are caused by HPV, meaning that they're almost entirely preventable by the HPV vaccine. So this HPV vaccine is extremely effective when given before exposure to the virus, ideally ages 9 to 14. It prevents about 90% of all HPV-related cancers. And clinical trials have shown that it's nearly 100% effective at preventing precancerous cervical lesions. What's more is that protection is long-lasting, with studies showing that there is immunity even 15 plus years after vaccination. And if you look at the graphic here, it also shows just how significant of an impact the HPV vaccine had, where cervical cancer death rates dropped nearly half after the HPV vaccine was introduced in 2006. And this really just shows how powerful of a tool that HPV vaccine can be in cancer prevention, but only if people get vaccinated. With that, let's get into the heart of the problem. While urban areas achieve HPV vaccinations of 60 to 70%, rural areas significantly lag at 40 to 50% or even lower, and this translates almost directly into worse health outcomes. So why does this matter for global health? Because rural populations represent nearly half of the world's population, and many of these areas lack OBGYN services and other barriers. And when multiplying these barriers worldwide, we're looking at millions and millions of people who face preventable cancer risks simply because of where they live. So this is a fundamental issue of health equity that demands our immediate attention. So let's look at what barriers specifically are preventing HPV vaccine acceptance. First, there's access. Many rural areas have limited healthcare providers, which means people might need to travel a lot of hours, or it means that there are month-long waiting periods for people to get vaccinated. There are economic barriers as well, where rural families often have higher rates of healthcare insurance and face higher out-of-pocket costs because of this. Social barriers are probably the most pressing, where lower levels of health literacy and stigma make it really hard for families to understand HPV vaccine risks and benefits. We'll go into this a little bit later. And finally, healthcare systems in rural areas face their own challenges with inadequate cold storage for vaccines and supply chain disruptions, as well as providers who might lack training in HPV vaccination best practices. So I'd like to take a moment, like I said, to speak about the specific social barrier to HPV vaccine acceptance, which is stigma. So many parents and teens associate HPV vaccination with sexual activity, leading to misconceptions that getting vaccinated is only necessary for sexually active teens or that recommending the vaccine promotes promiscuity. But the reality is quite different. And because we know that nearly 80% worldwide people are getting infected with HPV. So we are trying to break down the stigma through education and messaging because we know that this vaccine is essential for saving lives. So the stigma is what I focused on at my research project, where we recognize that generic HPV vaccination messages often fail to resonate specifically with rural communities, even though that's where this messaging is required. And our approach was to create culturally appropriate messaging, specifically a video, that spoke directly to rural values and concerns. So we didn't use a one size fits all strategy. We developed a targeted content that acknowledges their perspectives and priorities. And that really is what made this research innovative and unique. We recognize that health communication really means addressing their concerns by using imagery and language and values that resonate with your population's lived experiences. Further strategies that I wanted to share include mobile health and school-based programs with mobile vaccination clinics where it can eliminate travel barriers by reaching adolescents where they spend their time specifically. Provider training is also very crucial by teaching healthcare providers to use preemptive recommendations. We can strongly recommend strongly recommending the vaccine. It has shown significant success in increasing uptake rates in rural settings. Then there is community engagement strategies where we work with local leaders and religious figures and trusted peer educators who can help build trust in that community. And finally, as always, our policy solutions, where we can expand insurance coverage and implement vaccine requirements for school attendance. So let me just conclude by restating why addressing this divide is so important. And the key takeaway really is that the HPV vaccine is remarkably effective. And secondly, the stigma and misconceptions create additional barriers beyond the ones that already exist in rural areas, which is why we really need to focus on breaking that down. And finally, bridging this gap requires coordinated action where it's not just individual health providers, but everyone working together. So remember that we must build sustainable rural health infrastructure that ensures these communities have consistent access to preventive services. Health equity means that we need to make sure that geography doesn't determine health outcomes. These are my references, and a huge thank you to Dr. Victoria Churchill for supporting me throughout, and my high school teachers for encouraging my curiosity, and thank you to the listeners for listening to my presentation.